Thank you for the introduction, and thank you all for attending. Just so I have a sense of our audience, could you raise your hand if you currently do PFO closure in your practice? Okay, great. So a little bit more than half of the room. I do think that PFO closure is an exciting therapy. It has been a long time coming, and with regards to thinking about what's important to patients, it's certainly something we've been offering for a long time because of that sense that we are helping, but now we have the data behind it. I'm going to talk about 4 things in the next 10 minutes, and I'm going to start with a case. Recently, I took care of a 60-year-old man who had a small left parietal infarction, and he had a full recovery. But as many of you are taking care of patients who are coming to you for PFO closure know, even when they have full recovery, they're devastated by that event. They're so scared about that happening again. And this is really driving their interest in learning more about the options open to them. The patient did have some risk factors for atherosclerotic disease. He had a history of hypertension and some brief tobacco use. And the context of the visit was that my neurology partner had referred him for PFO closure. An important part of the way that we deliver care at Dartmouth-Hitchcock is that the gatekeepers are those that are expert in the diagnosis of stroke. And as we were just talking, as we build PFO programs together with our neurologists, we as cardiologists are learning so much about the intricacies of that. Specifically, the intricacies around the diagnosis of stroke and its etiology. So I'll walk you through the algorithm, and these are documents that have been created by Gore to help guide us through the workup of patients with PFO. But I'm sure many of you have met with patients who have a diagnosis of TIA, and they have a PFO. And currently the approval is for documented stroke. That is, we see evidence of stroke on an MRI. So we look first to make sure that we have acute ischemic stroke, and if we see atherosclerotic disease, we choose medical management. If we don't, we go on to vessel imaging, CTA, MRA, carotid ultrasound, looking again for atherosclerotic disease or other more rare vessel diseases that can lead to stroke. And if none of those are present, then we move to the embolic workup. And this is highly variable. We heard about this at an earlier PFO session at this meeting. Depending upon where you practice, you may engage your hematologist or not. The recommendations are, if there are any medical conditions predisposing them to thrombosis, like cancer, DVT or PE, or family first relative history of that, or an autoimmune disease, we think more about potential underlying clotting disorder, and we have them evaluated by hematology and a shunt evaluation, and we also make sure there isn't the presence of another cardioembolic phenomenon like atrial fibrillation. I'll just say a couple caveats that I think will be interesting for discussion after this talk about each of these aspects. If you have a patient who has a DVT of unclear etiology, do you recommend lifelong anticoagulation? And if you are recommending lifelong anticoagulation, would you still offer closure in that context? This is a question that comes up at every single PFO talk that I've been engaged in. And I have to tell you, in my own practice, I talk openly with patients about this decision. Will they be able to take anticoagulation perfectly every single day? Will they never have to hold that for an operation throughout their lifetime? We have data on adherence to DOACs, and we know that very few people are able to take it consistently more than 80% of the time. So it's not a perfect drug, so I do offer them the choice still in that context. The shunt evaluation can be challenging. Usually we're doing an injection through the arm IV. We know that shunts come really from the leg, from the direction of the PFO, so we may choose transcranial Dopplers or even to do a shunt evaluation through a femoral vein sheath in the lab. And then the length of monitoring is also very controversial. Most of us are now doing Zios or prolonged monitoring 2 to 4 weeks, depending upon the patient. Sometimes I'll do an ILR. In the future, will they just tell us what they found on their watch? So this particular patient had no history of cancer, personal clot, or first-degree relative with clot or autoimmune disease. He did not have any atherosclerotic disease. There was no atrial fibrillation found on his Zio patch that he could wear for barely 14 days because the patch is so irritating as usual. And his imaging demonstrated a high-risk PFO. He had been assigned a statin, as well as aspirin and Plavix after his stroke. And this is a question that comes up so much from young people. Why would I need to take a statin if I don't have atherosclerotic disease and my LDL is 90? Another point of discussion. So I have to be honest with you. Here's one of the reasons why I'm most excited about PFO therapy. I love intracardiac echocardiography. And this is a great way to get involved in it. As we think about using ICE or intracardiac echo in future structural procedures, including, for example, left atrial appendage, this is a great procedure to become more familiar with it. As you can see here, at the top of the screen is the right atrium, then you can see the septum and the left atrium and the Gore septal occluder being pulled back from the left atrium to the septum at the site of the PFO. It's terrific to have intracardiac echo as an option. Patients are wide awake during procedure and go home same day. Here's the closure, and you can see the device laying very flat across the septum, and the fluoro image with my ICE catheter leaning back to look at the final result. There are multiple randomized controlled trials with proven efficacy that were published in the New England Journal. I'll just review the one related to Gore septal occluder today. You all are familiar with this data, but one of the interesting caveats is, how do you communicate this data to your patients? The REDUCE study was looking at the superiority of PFO closure in conjunction with antiplatelet therapy compared to antiplatelet therapy alone, 664 patients, 7 countries. And here's one of the unique pieces that actually I was not as familiar with. Sites were told that they needed to have the patients take aspirin or combination aspirin dipyridamol or clopidogrel, and they were asked to use the same regimen for all patients. Those who got the device had 300 of Plavix and 3 days of Plavix. I think we'll hear more about that from our panel later. And what we found was that there was a significant reduction in stroke. I will share from the shared decision-making literature, best practices, however, are not to share relative risk with patients, rather absolute risk. And we know that when we think about 1,000 patients, 12 would have a stroke with medical therapy alone, and 6 would have a stroke with device. So the absolute risk is not as great as the relative risk shows, but there is definitely across multiple randomized controlled trials a significant decrease in the lifetime risk of stroke with closure versus medical therapy alone. And that's the benefit. Patients want to know, what about the risk of the procedure? When they're thinking about a heart procedure, sometimes they come to you and they think that they're going to have surgery. There's a lot of misconceptions about the device. Luckily, it is a safe and predictable procedure. With the Gore cardioform septal occluder, it has a very soft PTFE that's surrounded by a platinum-filled nitinol and conforms very well to the PFO anatomy with rapid healing. And we'll hear a little bit more about adverse events. I do agree. I think atrial fibrillation is the one that's most common, typically lasts less than 3 months, but is very problematic for patients that we're hoping to not have to be on anticoagulation. So that's another point of discussion about whether you feel compelled to start that in the context of AFib related to a device. But the overall serious adverse events are less than 4 out of 100. It's a very well-tolerated procedure, and these young folks really want to know, when can I go back to work? When can I go back to my regular activities? And the length of the procedure is short, and people are usually back to work within a few days. There is good reimbursement for this as well, which is important for our growing structural programs, of which PFO is an important part. And what do we expect from the future? How many ischemic strokes are cryptogenic? Well, there is certainly a large number. 1/3 of ischemic strokes are found to be cryptogenic. A lot of them are atherosclerotic, as you can see here. There are still a significant amount that are cardioembolic, but 200,000 cryptogenic strokes occurring annually in the US. And there is certainly a connection to PFO. When we're thinking about cryptogenic strokes, we're thinking about other causes, including the one we don't want to miss, which is occult paroxysmal atrial fibrillation. But 40 to 50% of patients who've had a cryptogenic stroke have a PFO. When we think in the general population, probably about 25%. So as you probably know, one of my other passions besides PFO closure and intracardiac echocardiography is shared decision-making. And the question is this a decision that's appropriate for shared decision-making? It's certainly been talked about in the past when we had less data. There's a little bit of confusion. What does shared decision-making mean? Does that mean a shared decision between the neurologist and the cardiologist? No, we're talking about a shared decision between the patient and their clinician. But shared decision-making is most appropriate when there are two reasonable options that provide different risks and benefits for which patients' values and preferences distinctly differ across patient populations and perhaps differ from our own. And I would suggest that in this particular situation, the weight of the evidence favors one option over the other. The reduction in stroke is what most of our patients are most concerned about when considering a relatively safe procedure that can give them that benefit. There are decision aids out there, though, that you could use with patients, certainly those who have more concerns or are more uncertain. This is a decision aid from the MAGIC app, which compares PFO closure to antiplatelets and goes over the comparisons of the benefits and harms for patients. And I list the web page down there below, but if you type in MAGIC app decision aid PFO closure, you'll find it. It's one that you can use during the visit with your patient. But for this particular decision, the panel agrees. Most patients' preferences and values will be to reduce their risk of stroke over time. And when faced with a low-risk procedure, typically there's not a lot of differences with regards to patient choice. So I do think it's an exciting time for PFO closure for multiple reasons. We can definitely share with patients that we have evidence that we're able to reduce their risk of stroke over time. We can learn new structural imaging modalities like ICE, and we have excellent reimbursement to help grow our structural programs. And I think ultimately this is becoming a more maturing therapy because of all of the hard work of those that have come before us to make sure that we have the data to share with patients. So I'd like to open it up for any discussion points based on what I've presented so far, if people would like to come to the mic, or if there are comments from the panelists.
That was a great talk, Megan. Quick question for you. So you mentioned that the approval for the procedure is for individuals that have strokes and not necessarily TIAs, and that's one issue that comes quite frequently. I mean, we all see patients that have TIAs and not without evidence, MRI evidence of a stroke. So my first question is, how do you see these patients, and when you discuss with both the patient and the referral doctors what the indication for closure and specifically for a suspected TIA? The second is, how do you envision the issue of the PFO morphology in your conversation with your patients, for example, the presence or absence of a septal aneurysm or the size of the PFO? We still get a lot of pushback by certain, a portion of the medical community refers patients that they only refer individuals with large PFOs, and which, by the way, is a neurologist reading an echo report without necessarily having the expertise to look at the images. So could you comment a little bit about those two issues?
I think what you're asking is there's still a lot of gray area in the decision making, and also there are patients who are not referred because of that. I do think this is a case where I readily admit that I am not an expert in TIA or stroke. And so I feel that it is incumbent upon us to partner with our neurologists to help make that decision. If they feel that this is a true TIA and not a migraine or some other etiology, we have been treating patients who are high risk for stroke with PFO off-label for a long time. So I do offer that therapy if we feel as a team that this is a likely etiology of their TIA and if that matches with the patient's values and preferences. So I don't think that we're limited necessarily by the approval. We certainly haven't been for the last decade when we were closing PFOs for patients who had stroke. But I think that the morphology of the PFO is really important. I mean, what we're trying to guess is whether this TIA is related to that PFO. And so I would certainly be more exuberant in my recommendations if there were high-risk features.
Correct. That's exactly the same way we look at it. TIAs still should be closed if they have a high-risk situation, like you said, and the trials have shown a bit of a not consistent data about the size as a predictor of benefit, but there are studies that have shown that even smaller or small PFOs still benefit for a stroke reduction. So
I just want to add to what you said, Megan, because it really does hit the nail on the head. And if there's one therapy where patient selection is so important is this one. You have probably 25% of the room has a PFO, and a lot of ischemic stroke victims. So coincidental findings are certainly common, and it becomes incredibly important in selecting your patients, and that's going to depend on clinical variables, anatomical variables, and obviously the comorbid conditions presenting. So that's part of I think, builds with experience and time, but that's where the art of medicine really kicks in selecting patients for PFO closure, I think.
I
Question?
have a question in the audience, yeah.
Question for the panel. It's really a two-pronged question. How are you addressing older patients who are deemed to have cryptogenic strokes and PFOs when the trial data is really in the younger patients? And secondly, are you utilizing risk assessments like the ROPE score in your assessment, and how is that part of your evaluation?
So I can take the question. Again, it goes down to patient selection. I recall a patient we did 2 months ago, in his elderly 70-plus-year-old gentleman. They came in, had a central line put in, and a few days later had a massive stroke. He was studied. The gentleman had a very large PFO, and he was considered for closure. And so we did close him, over time. So I don't think age alone should be a discriminant. I think the studies were designed that way to eliminate confounders. And to clean out the data as much as possible. But we've proven efficacy. We've proven that the mechanistic implications of PFO closure in preventing strokes. So I think it's fair to say that, if you have the right patient subset, despite their age being a little older, that is the right thing to do. Now, if they're diabetic, they have atherosclerotic disease, and they have AFib, and that's a completely different story.
The approval is for predominantly patients 18 to 60, which gives us the ability to make the decision about whether it's clinically appropriate. I do monitor my patients in their late 70s for much longer for AFib. I had a case about 3 months ago where I had a gentleman have an ILR for a year, no AFib. I closed, that'll be to your talk, he developed AFib right after the closure. And that did go away after 6 weeks. But I was so glad that I had that long-term monitoring to know this was likely related to the device. Whether people are more sensitive as they age, I think obviously we don't have any data on that. But I will go to extra lengths to make sure that there are not other factors that may be contributing to their stroke risk.
I just want to add that the reduced post-approval study is going to include a population of 63 patients between the age of 61 and 70 that the FDA has allowed to include in the clinical trial to be able to at least have an idea how they respond and what's the benefit in that particular population. So I know Megan is required in many places in this meeting, so you're off you go.
Thank you for the invitation.
Thank you, Megan.